Good day, and welcome to Epstein Becker Green and EBG Advisors webinar series, The Effect of the Average Manufacturer Price Final Rule on Drug Pricing and Contracting. Today's session is Part 2, Opportunities and Barriers in Pharmaceutical Pricing. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You're welcome to submit questions throughout the program by using the Q&A feature provided by WebEx, and at the end of the program, with time permitting, the speakers will address your questions. You are also welcome to submit questions directly to the presenters following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We are pleased to have 2 fantastic speakers today. Dr. Samuel R. Nussbaum is a strategic consultant at EBG Advisors, and Lesley R. Yeung, who is an associate at Epstein Becker Green. At this time, I'd like to turn the webinar over to our speaker from yesterday's first session in the series, Connie Wilkinson, a member of the firm at Epstein Becker Green.
So yesterday we were going through an overview of some of the revisions made in the AMP final rule that was recently issued by CMS. Today we'll be focusing more specifically on value-based pricing, some of the regulatory issues around that, and some of the experiences that people have had to date with that. We're excited to have Sam and Lesley on the panel today. Sam brings a clinical health policy focus to these issues as a former chief medical officer, and he's had significant experience grappling with value-based pricing constructs from a third-party payer perspective. Lesley comes at this issue from both a health policy and a health regulatory perspective based on her expertise in Medicare, Medicaid, and third-party payer reimbursement, as well as industry developments in payment models. So we're looking forward to them sharing their experience with us today.
Good afternoon, everyone, and thank you, Connie. This is Sam Nussbaum, and this is an extraordinary time in terms of the pharmaceutical and life sciences perspective. And Lesley and I are going to share, as Connie said, a perspective on where value-based contracting and pricing is going in the drug space. We're going to look at it from a government perspective as well as a private sector perspective. And I think what's most important, like the opening of a Dickens' Tale of Two Cities, it's the best of times now and the worst of times. The best of times because we have such breathtaking life sciences, breathtaking discovery in science. We all have seen the focus by the president on personalized medicine, the vice president on moonshot. We have patient-centered outcomes and advanced data analytics, and all of this is framing an opportunity to take the fruits of discovery and make a difference in clinical care. In fact, if we look over the last decade, the dramatic reduction in coronary disease, the fact that we've turned HIV/AIDS into a chronic illness. This is all the fruits of fundamental science, innovation, and discovery. Yet, we know that the cost of drugs and their affordability, we know there are issues that are related to value-based payment models that have both regulatory and operational perspectives. Those are some of the forces that we're going to take on today. This slide actually from Pharma Trade Group is a summary of the impact of the pharmaceutical industry. And what's salient here is that it costs as much as $2.6 billion to develop a drug. And that's a result of not only the successes in drug discovery, but those molecules that don't make it to the final FDA approval. We know that R&D is a very significant component of the pharmaceutical industry, but marketing is also. There are almost 800,000 jobs in the pharmaceutical sector, and we're seeing that the fruits of all of this work have resulted in more than 500 new drugs since 2000. But what's really impressive is the fact that there are 7,000 medicines in development around the world, and many of these are potential first-in-class medicines. So discovery and innovation will continue to be at the forefront. And as we said before, drugs have made an impact in care. So when we look at issues such as the price of a drug, we need to very much consider the overall impact on the healthcare ecosystem. An example would be a drug for heart failure. We'll talk more about this later, but a drug for heart failure that can improve the quality of life, reduce hospitalization, has a value that goes vastly beyond the price of that drug. Now, what's important, I think, for all of us to appreciate is how rising healthcare costs that we see today are not sustainable. In fact, some of you who've been in Washington have seen articles even today in the Washington Post and Political Pro, Forbes. I bet Roy had an opinion piece in Forbes, and each of these is talking about how do we begin to get solutions. Because if we look over the last decade, there's been virtually no growth in earning for the average American household, from about $49,000 to $53,000. But if we look at the costs of health care, they've moved from $9,000 to almost $25,000. Now, there's a conventional wisdom that I'm not sure it's a wisdom. It's certainly not accurate. But it is that why are we so concerned about drugs or new pricing models or value-based contracts when they represent only 10 to 12% of total healthcare expenditures? Well, the fact is they represent far more than that. And we know that today this is particularly true in specialty pharmaceuticals. So let me share some information with you that represents commercial health plan payment. Today, if we look at drugs through the pharmacy benefit and through the medical benefit, in addition, if we include drugs that are used in the hospital, drugs today represent 20 to 25% of the total medical premium of healthcare spending. Now, you might ask, well, that's commercial. What about Medicare? And if we look at the MedPAC trustees report, drug spending accounts, if you think of Part B, and we're going to talk about that, Connie alluded to a lot of that yesterday. I am sure, and Leslie's going to talk about the Part B demo. But if we look at Part B and Part D and Medicare Advantage, that drug spending accounts for almost 20% of Medicare expenditures. And what's most impressive is that specialty drugs are rising at a mid-teen clip, that they today represent 30% of all drug spending and will reach $400 billion or 50% by 2020. So drug costs are major, and they're growing and are having an impact on Medicare, Medicaid, and exchanges. So just again to emphasize this growth rate and to look at specialty drugs are generally given by injection. Some may be oral drugs that are just very expensive, such as the HIV drugs or hepatitis C drugs that have been the focus of attention. But again, total drug spending today is closing in on $500 billion. That's total drugs, and specialty drugs will be $400 billion. So we have an ever-increasing spend. Now, what's so important, if we look at it from the consumer view, and this is what's happening now as both the Republicans and Democratic conventions get underway, is if you ask consumers, voters, what's number one on their mind in healthcare, it's really about drug costs. And over 80% from a Kaiser Family Foundation study are asking justification of drug prices. Many think that Medicare should negotiate for prices, put limits on drug prices, want imports from Canada. And in fact, the reason that this is so relevant is not just the cost to government and to payers or employers, is that people do want access to treatment. And people do take drugs 50 to 70% regularly, so it impacts everyone. And if you think of Medicare, there's really no out-of-pocket limit for Medicare Part D drugs as there is for on exchanges for other health benefits. So I have placed some quotes here from our presumptive nominees, who will be the nominees, but Hillary Clinton, acknowledging that we're paying the highest prices for drugs in the entire world, and speaking about the fact that there is no regulation at all on pricing. And you see Donald Trump commenting that having the second or third most powerful lobby get the politicians. Every one of them is getting money from them, and when it comes to negotiate the cost of drugs, he proposes negotiating like crazy. So what we look at, and before turning this over to Lesley, I want to sort of share a little bit how private health insurers like Anthem and others look at medical coverage and drug coverage. And I've placed here some information from Anthem, where all of the health plan coverage policies are on the website. The medical necessity is determined. There's absolutely references to peer-reviewed journals. These decisions are made in large part by external organizations. So the pharmacy process, they're medical and pharmacy processes that are aligned. But in the pharmacy process, it's a two-step process that evaluates the quality and outcomes first, that's foremost, and then cost. So a clinical review committee of medical experts, none of whom are working for the companies, actually, in this case, Anthem evaluates the research and the FDA information and reaches out to expert groups and classifies drugs into a number of categories. But it's only after that assessment of whether drugs are favorable or comparable does a second group, a value assessment committee, that does what's termed a pharmacoeconomic review, looking at the total impact and cost of care, looking at convenience, looking at quality. All of those issues lead to how a formulary is determined. I want to turn it over to Lesley because we have again, that's a private sector focus, and I've given some numbers on how private sector companies make decisions on formularies, but certainly there's been increased focus from the government, starting with convening many stakeholders last year. Lesley?
Great, thanks, Sam. So exactly as Sam has alluded to, there's just been a lot of attention on the rising cost of prescription drugs from Congress, government researchers, MedPAC, and the federal agencies. And it seems like, also as Sam mentioned, news stories are just coming out almost every day about the impact that these rising costs have on federal and state healthcare spending. So last November, HHS convened a forum to bring stakeholders together to discuss this issue. So industry representatives and representatives from state and federal government participated in discussions on various topics over this one-day forum. The topics included how to balance innovation and rising drug costs, how to provide access to affordable drugs, different models for rewarding quality of care that drives increased value, innovative purchasing strategies, and how to implement value-based and outcomes-based drug purchasing programs. If you're interested in watching, these discussions are actually available for viewing online at the website listed on this slide. On the next slide, following the Pharmaceutical Forum, CMS released an online dashboard with the intent to increase transparency around Medicare Part B and Part D drug spending. CMS identified 40 Part B drugs and 40 Part D drugs to include in the dashboard, and that was based on drugs with high spending on a per-user basis, high spending for the Medicare program overall, and high unit cost increases in recent years. Next slide. For the 80 drugs that CMS selected to include in the dashboard displays a whole variety of information, such as total Medicare spending, total annual spending per user, average annual beneficiary cost-sharing amounts, beneficiary utilization of the drug, and trend data related to annual changes in the average cost per unit of the drug. The dashboard also displays information on the drug itself, such as the product description, the manufacturers of the drug, and clinical indications. So while the dashboard doesn't provide information on the clinical or financial value of any drugs, it does include links to evidence-based practice center reports. These come out of AHRQ, which synthesize evidence on the effectiveness and harms of the drugs when used by certain populations for specific conditions. CMS has stated that it's planning to update the dashboard on a regular basis, and it also plans to release similar information for Medicaid drugs this year. Next slide. So in addition to the department's efforts to increase transparency around spending on drugs, another avenue for addressing the issue of rising drug costs is to look at the effectiveness of various treatment options to help patients and providers determine which treatment options are the best for them. The Affordable Care Act created the Patient-Centered Outcomes Research Institute, or it's called PCORI, which is a federally funded nonprofit corporation that focuses on funding and disseminating comparative clinical effectiveness research findings. The clinical effectiveness research is defined in the statute as research evaluating and comparing health outcomes and the clinical effectiveness, risks, and benefits of two or more medical treatments, services, and items. So PCORI began operation in 2010, and over the past 6 years, it has defined the field of patient-centered outcomes research that it will be engaged in. It identified national research priorities. It established a research project agenda, and to date, it's funded about $1.4 billion worth of research studies, as well as methodology and infrastructure projects. When I put this slide together about a week ago, there were 780 funded projects listed on the PCORI website, but that list has already grown to just over 800 as of today. But interestingly, to date, PCORI really has only funded a limited number of studies related to specific drugs, medication adherence, and treatment outcomes. So I'm going to turn it back over to Sam to discuss how comparative effectiveness research can promote value and innovation.
Thanks, Lesley. I think what's so important is that all of us, as we look at value in pharmaceuticals or devices or any interventions, have been promoting comparative effectiveness research. In fact, I believe that two of the jewels of the Affordable Care Act include the Patient-Centered Outcomes Research Institute, as well as the Center for Medicare and Medicaid Innovation. But in fact, one of the considerations as PCORI was established was there was significant concern that price and cost would be taken into account in a significant way. And so there's specific prohibition to look at a number of the specific cost issues. So it's very hard then for PCORI to take the same approach that NICE, the National Institute for Clinical Effectiveness, has taken in the UK, or some of the other government agencies. So here was this focus with extraordinary amount of funding to look at treatments and comparing them, and yet there was not an ability to look at cost, just in outcomes and quality. So I think what's key is that comparative effectiveness can make a huge difference. It can address unsustainable healthcare costs. It can look at how we can use resources to get better or comparable health outcomes at better value. And most importantly, it can help patients choose more effective treatments. What is so clear for most of us who've been focused on this type of activity is that Americans deserve, and our nation deserves, the investment in care that makes a difference. So it is essential that we then say superior treatments get covered. Comparable treatments, for example, if you're lowering cholesterol and you have comparable statins, then those should be chosen on value. And personalized treatments really need to be managed by physicians and patients. And as we move into this era of understanding the molecular basis of certain cancers and the profiles of how certain drugs work, we're going to see much more of this type of investment. What all of us have a responsibility in effectiveness research is to remove inappropriate or ineffective treatments. And we know from many outcome studies that as many as 1/3 to 40% of all treatments that are given do not have better health outcomes. So again, on the right side of this graphic, you can see that superior deserves investment, comparable deserves value, personalized is what the future will be about, and ineffective needs to be removed. But as Lesley will now share, there also are organizations that are emerging that are looking at comparative cost-effectiveness analyses that have not been government agencies, but other agencies that have been established in other organizations.
Great, yeah. One example of this in particular is the Institute for Clinical and Economic Review, or ICER. Through its research, ICER analyzes evidence around medical interventions and develops a rating for comparative clinical effectiveness and a rating for comparative value, which is based on analysis of the incremental cost effectiveness of the intervention compared to an alternative treatment pathway. In July of 2015, ICER announced the creation of a new program, which it called the Emerging Therapy and Assessment Pricing Program, or ETAP, which is focused on assessing the cost of new drug treatments in comparison to existing treatments. Through the ETAP program, ICER intends to conduct a number of new drug assessments this year, including drugs used to treat a variety of conditions that I've listed here, such as diabetes, asthma, cirrhosis, Duchenne muscular dystrophy, lung cancer, multiple sclerosis, and psoriasis. To date, this type of research has had limited impact on coverage decisions or pricing negotiations between insurers and manufacturers, but it could be a growing area. On the next few slides, Sam is going to discuss some examples of efforts in this area to associate value with various drugs.
Thank you. So what you see now is an assessment done by the California Technology Assessment Forum, which really is a ICER-related organization. And this is about Sovaldi. Just to step back in time, you all recall that with the breakthrough drug Sovaldi, a drug that can cure hepatitis C that impacts 3.2 million Americans, there was an opportunity to look at and assess its impact both on cost and outcomes. And you also may remember, because the nation was galvanized around drug costs as a result of Sovaldi costing about $84,000 for a course of treatment. And on a clinical front, for many people with certain types of hepatitis, you had to add that to another drug called Alisio. So patients were being treated for about $160,000, but with high cure rates, which of course is really what we want to see in drugs. So this is an example of the assessment that was done, and the conclusion was that even in a 20-year horizon for all patients who had hepatitis C, the cost offset would only cover 2/3 of the initial drug cost. But what this slide is really intended to do is to show the dynamic issues involved, because if we fast forward through additional new treatments, including Harvoni, the price has come down from the 100,000 plus range to now in the 50 to 55,000 range, and sometimes less. And so the type of assessment that either a Quarry might spend a lot of time doing, or ICER or others, would need to be reassessed as there's competition in the market and drug prices have come down. And it's really that type of approach that people are now beginning to say, how can we look at differential pricing? So for example, if someone has an extraordinarily positive result from a drug and someone has less of a result, can we look at differential pricing? So Express Scripts began a concept that they're just introducing now called paying for results by indication. So if a person were to take a drug that decreases inflammation, a drug that might be used in rheumatoid arthritis, a drug that might be used in multiple sclerosis and has an extremely positive response, or a drug that might even be used in cancer, and another patient has less of a response, would you, in fact, charge different prices? Now, the way different prices are charged is actually to rebate varying amounts after the drug is initially paid for. It's complex, but it gets us to what we'll be talking about a bit later in this webinar, which is, do we have the regulatory and a framework to do this type of indication? Because today, under government pricing for 340B programs or Medicaid best pricing, if someone is getting an 80% rebate on a drug because it was not effective, would that have to be the government best price? So those are some of the issues we're going to get into as we move forward in the discussion. But what I'd like, again, to do now is to begin to look at this whole concept that began yesterday with Connie, and Lesley's going to take us through the concept of value in healthcare, some of the government programs and payment demonstrations, and really where we're going with value-based payment.
Great. Yeah, another creation of the Affordable Care Act, as Sam mentioned, which is housed within CMS, is the Center for Medicare and Medicaid Innovation. The Innovation Center was specifically created to test innovative payment and service delivery models to reduce program expenditures while preserving or enhancing the quality of care furnished to Medicare and Medicaid beneficiaries. The Innovation Center, interestingly, has authority to expand the models that it is testing, including on a national basis, if certain criteria are met. So if the Secretary determines that an expansion is expected to reduce spending without reducing quality or improve quality without increasing spending, and the CMS Chief Actuary certifies that such an expansion would reduce or not increase net program spending, and the Secretary also determines that such an expansion would not deny or limit coverage or provision of benefits for applicable individuals, then the Secretary can choose to expand models that the Innovation Center is testing. And to date, this has been done twice. The Secretary and the CMS Chief Actuary have certified the Pioneer ACO model and the Diabetes Prevention Program as meeting these criteria for expansion. Next slide. So the Innovation Center is testing a wide variety of payment and service delivery model reforms right now, including accountable care organizations and similar care models that are designed to incentivize healthcare providers to become accountable for a patient population and to focus on care coordination for that population. Evidence-based payment initiatives or bundled payments are for healthcare providers that are being held accountable for the cost and quality of care that beneficiaries receive during an episode of care. And an episode usually begins with a triggering healthcare event, such as a hospitalization or chemotherapy administration. And that episode extends for a limited period of time thereafter, such as 30 to 90 days. Primary care transformation models, such as advanced primary care practices or medical homes, utilize a team-based approach to emphasize prevention, health information technology, care coordination, and shared decision-making among patients and providers. And there's other initiatives being tested that focus specifically on care delivery for the Medicaid and CHIP populations and dually eligible beneficiaries, as well as other models to accelerate the development of new payment and service delivery models. To date, the Innovation Center hasn't really focused specifically on new payment or delivery models for drugs, but as I'll discuss later, that may be changing. Next slide. In 2015, the Secretary of HHS announced measurable goals and a timeline for moving Medicare payments from the traditional fee-for-service to alternative payment models, such as those that I just described that are being tested by the Innovation Center. Specifically, by the end of 2016, 30% of Medicare fee-for-service payments should be tied to quality or value through alternative payment models, and 85% of Medicare fee-for-service payments should be tied to quality or value measurements. By the end of 2018, these goals increased to 50% of Medicare payments being tied to alternative payment models and 90% of payments being tied to quality or value measurements. Earlier this year, Secretary Burwell actually announced that the goal of tying 30% of Medicare payments to alternative payment models has already been reached. And as the Innovation Center continues to test new models, as well as the physician payment reforms enacted by the Medicare Access and CHIP Reauthorization Act last year continue to come online, this should allow for the Medicare program to continue on this path to paying for value over volume. I'm going to turn it back over to Sam to discuss the work that's being done to promote alternative payment models across the public and private sectors by the Healthcare Payment Learning and Action Network.
At the same time, thank you, at the same time that the President and Secretary announced these ambitious goals to move payment to value-based payment, they established the Learning and Action Network, and the concept here was to bring public and private sectors together to align interests, to align measurement, to align quality performance, and to move the entire payment innovation in the U.S. forward. And I had the privilege, and I serve on that guiding committee, and had the privilege to chair the group that actually developed the framework that you see in this slide, and also where we are today. In fact, there's a national survey that will be available by the fall to see where the private sector is. As Lesley said, we know that the Secretary has announced that CMS has already achieved 30% of payment in these alternative payment models. And we know, and I know there's both energy around this, but also for many providers, they're seeing many of the activities of CMMI literally weekly as there's, we'll talk about later, but as there's movement to these models. What's key is that there's a clear strategy to move the delivery system to categories 3 and 4. So these are alternative payment models that, while they either may be built on a fee-for-service architecture or may be so-called capitated or population-based payments, what's important is they put providers at risk and opportunity for improving care. Category 2, which we've broken into 4 subcategories, is sort of a, think of it as a gateway to paying for quality and linking to value. Many regions of the country and rural areas, and there are specialties that will stay in Category 2. But what's important is that as an organization, both private and public, we've said that drug costs all in should be involved in Category 3 and 4. So what we have is a frame where we're moving to transparency, to alternative payment models in hospitals and physician areas, and yet we've not made that same move in the drug area. So if you take, if you look at this next slide, the goal is to move from the current state to a future state, and you can see this is a representation of where we are today and where we want to be. So again, more movement into population-based payments. But what it really does, if you look at the vertical axis here, is that as you move across these categories, the providers have greater accountability, and they have also greater opportunity to innovate and care. There's a greater impact on quality performance, coordination, integration. We know what you're lacking in our delivery system, and what we've all suggested as person-centered care. So let's now see how these big themes begin to play out in terms of paying for value and drug pricing, and we'll together give some stories, examples, and then conclude with what needs to be done going forward, and then hopefully await your questions.
Great. Well, this is Sam's slide, but I just like it so much. I think it really sets up the discussion on value-based payments so well. As this slide illustrates, the notion that physicians should be paid based on the outcomes they achieve is clearly not new. But the current Medicare payment system doesn't provide appropriate incentives to encourage providers to focus on the quality of the care they furnish, but rather rewards them for the quantity of care furnished to patients. Next slide. So as we think about moving toward value-based payment arrangements for drugs, I wanted to discuss some of the important trends occurring right now in the Medicare program for physicians. You know, those are the physicians who prescribe drugs. I mentioned MACRA briefly before, but I'd like to discuss in a little more detail the physician payment reforms included in the MACRA legislation. MACRA was enacted in April of 2015 to eliminate the sustainable growth rate formula that had basically plagued the Medicare physician fee schedule updates for about 13 years. In eliminating the SGR, Congress laid out a framework for reforming the way in which Medicare will pay physicians. In general, MACRA creates two funding streams for clinicians based on their participation in either the merit-based incentive payment system, called MIPS, or alternative payment models, APMs. Congress left a lot of the details to CMS to figure out how this would be implemented, and the agency just issued a proposed rule on May 9th that lays out how they envision MIPS and APM participation to take shape. Comments on the proposed rule were due on June 27th, and a final rule is expected to be published on or around November 1st. Next slide. MIPS is intended to streamline the various physician quality programs that are currently in place, including meaningful use, the value-based payment modifier, and the physician quality reporting system programs. 2018 will be the last year of reporting under each of these existing programs, and they will be rolled into MIPS starting in 2019, which is the first year that MIPS payment adjustments will be applied to clinician payments under the Medicare physician fee schedule. A clinician's MIPS payment adjustment for 2019 will be determined based on his or her reporting, and performance was proposed to begin in 2017. Although I just noticed today that CMS Administrator Andy Slavitt said during a Senate Finance Committee hearing today that CMS could consider possibly delaying that start date because there's been a lot of pushback about the speed with which clinicians will have to come up and be prepared to participate in MIPS. So a clinician will receive a composite score for his or her performance in 4 categories. These categories are quality, resource use, clinical practice improvement activities, and advancing care information, which is related to EHR adoption and use. Clinicians receive a positive, negative, or neutral payment adjustment based on how their composite performance score for each of the 4 categories compares to a base performance threshold. Clinicians falling below the base performance threshold will be subject to negative adjustments. These adjustments are capped, but the percentages increase each year up to 9% in 2022. And then positive adjustments for performance above the performance threshold must be paid out in an amount that's equal to the total negative adjustments made to clinicians. There's also an additional payment adjustment possible for exceptional performers. So in the next slide, you may be wondering what all of this has to do with drugs or payment for drugs. This slide just gives a general overview of how the utilization of drugs can impact a physician's performance under MIPS in each of the 4 categories, and in turn the potential payment adjustments that a physician could receive. So generally these are things to keep in mind that could either drive or tamper a physician demand for certain drugs. Generally, there are quality measures, clinical performance improvement activities, and advancing care information measures that relate to the use of certain drugs, the documentation of a patient's current drug use and potential drug interactions, and participation in medication management programs, among others. One thing to note for future consideration is that CMS stated in the proposed rule that it intends to consider how to incorporate Part D drug costs into the resource use performance category. So over the first few years of the MIPS program, there's a gradual increase in the impact that these resource use measures will have on a clinician's composite score. So however CMS decides to incorporate drug costs into resource use measures, if they do at all, will be increasingly impactful on the payment adjustments that physicians receive under MIPS. And next slide. I'm not going to spend much time on this slide, but in general, the second pathway to physician payment reforms is through clinician participation, APMs. If a clinician participates in what CMS has defined in the proposed rule as an advanced APM, he or she will be eligible for an annual lump sum bonus of 5%. And there are certain characteristics that an advanced APM must have, such as the physician must take on more than nominal financial risk. They must report quality measures that are comparable to the measures adopted under MIPS, and there must be use of certified EHR technology. CMS they've established a pretty high threshold for APM participation, and so the expectation is that not many clinicians will qualify for the 5% bonus in the first few years. Next slide. So we've been alluding to this. Another major proposal that came out of CMS in the Innovation Center earlier this spring is the Medicare Part B drug payment model. In March, CMS announced that it plans to test new models to pay for prescription drugs under Medicare Part B. The first phase of the proposal would be to test whether changing the current add-on payment to the average sales price from 6% to 2.5% and paying a flat fee of $16.80 per drug per day, whether that will change prescribing incentives for physicians. The second phase of the proposal would be to test value-based purchasing arrangements for Part B drugs. The proposal is pretty massive in scope in that all providers and suppliers furnishing and billing for Part B drugs would be required to participate in the model in some way. So, for example, under the first phase, all providers would either be assigned to the new payment mechanism or serve as a control group under the existing ASP plus 6 payment mechanism, and that will all depend on their geographic location. Next slide. CMS didn't really provide much detail about how value-based purchasing arrangements would be tested under the second phase of the Part B drug payment model, but CMS did give some examples of the types of arrangements that it's interested in testing. So specifically, CMS mentioned arrangements that discount or eliminate patient cost sharing to encourage the use of certain high-value drugs, creating evidence-based clinical decision support tools to provide feedback on drug utilization, testing variations in payments for a drug based on the clinical effectiveness for different indications of the drug, setting a benchmark price for therapeutically similar drug products, and allowing CMS to enter into voluntary agreements with drug manufacturers to link patient outcomes with price adjustments. And next slide. So this proposal has been met with a tremendous amount of criticism and a lot of calls for CMS to withdraw the proposal. House and Senate members have submitted letters to CMS requesting its withdrawal, and Dr. Patrick Conway from CMS testified at a contentious hearing in front of the Senate Finance Committee about 2 weeks ago on the implementation of the proposal. There's been various concerns that have been raised, but generally those involve limits to patient access to drugs and impact on quality of care for patients. And there's also concerns that the proposal, it's just too broad in size and scope, and the Innovation Center is really overreaching on its authority to test alternative payment models here. Those who do support the proposal have suggested that tweaks could be made to address these concerns, such as creating an ombudsman program, requiring a monitoring and corrective action plan to deal with unintended consequences, or establishing multi-stakeholder advisory panel to consult with CMS, limiting the size and scope of the demonstration, and providing an exceptions process for small and rural providers. Next slide. CMS received over 1,000 comments on the proposed rule from a wide array of stakeholders. I just picked out two here, Pharma and Bio, two major trade associations for the pharmaceutical industry. They both urged CMS to withdraw the proposal. Pharma raised concerns about the imposition of value-based price regulations and the assumption that the current ASP plus 6 payment mechanism is leading to inappropriate care. Bio also raised concerns about patient access to care, and they suggest identifying more discrete opportunities to test demonstrations that are more limited in scope and don't expand the Innovation Center's authority to test payment reforms. The release of the final rule by CMS will obviously be greatly anticipated. Everybody wants to know what CMS is going to do here. CMS actually proposed that the first phase of the model could go into effect as early as this fall, and the second phase as early as January 2017. So doesn't give much time for implementation. I'm going to turn it back over to Sam now to discuss what it means to implement value-based payments for drugs, various opportunities and barriers that may exist, as well as some real-world examples.
Thank you, Lesley. What's so interesting is with 1,000 comments for Medicare Part B, Andy Slavitt earlier this week shared that there were 4,000 comments on MACRA. We imagine that all of you have been very busy writing comments, but let me at a high level, share some information on what are value-based reimbursements for drugs, because we said earlier that drugs have stayed in a very traditional way of pricing. And so many of the early approaches were to reward persistency of drugs. So did people take their medications for blood pressure, for high cholesterol? But when we speak about value-based arrangements, we're really talking about a clinical outcome that occurs at the individual patient level that may be predetermined and certainly will lead to better care. And much of this is through rebates on products where you don't achieve the desired result. So this is a framing of where we are. It's certainly a challenging terrain. It's an evolving landscape, and it requires new ways of thinking. What are the clinically relevant and measurable metrics or outcomes, as an example? This is challenging in oncology. Are we looking at survival, quality of life, tumor shrinkage? What about long-term chronic illness, such as multiple sclerosis? How do you actually manage that over a long time when the pricing of drugs takes place on a yearly basis? If we look at the market experience, some of the earliest experience goes back some years ago when there were discounts offered and better formulary placement and better copay for patients for certain drugs for diabetes based on how much better their diabetes was in control. Their experiences on looking at spine fractures or non-spine fractures while on treatment with bisphosphonates, drugs that are used in the treatment of osteoporosis. But in the last months, Novartis has a heart failure drug called Entresto, and Cigna and Aetna arranged with Novartis that that drug will be priced based on the reduction of hospitalizations. This is a true value-based arrangement. Amgen and Harvard Pilgrim Healthcare looked at Repatha, which is a PCSK9, a drug that lowers cholesterol to profound levels, but has not been yet proven to reduce heart attacks or prevent cardiac death. That work is coming. But what they did is to say if it lowers cholesterol to the level seen in clinical trials, then we will pay for it. If not, we will not. But if you look around globally, that this type of contracting is much more common in Europe and also in Australia. The same way that add on biologics that are more common in Europe. So what I thought we'd conclude with is just a story again, but I'm going to frame it in cancer care. And what this does, it'll emphasize what Lesley shared on the Part B demonstration projects and why this has been such a thorny issue and had such a reaction. And we'll look at cancer care. It's certainly a system that the Institute of Medicine in 2013 looked at and said that we need to improve the quality of cancer care. We know that 1/3 of patients are not getting state-of-the-art care. We know that there's not a system of care in terms of palliative care, and that decisions are not made on the latest scientific evidence. So this next slide actually shows what the price of new oncology drugs are. Today, most oncology drugs are costing $100,000 a year. And in this work, you can see that the survival in many instances has been extended for patients by only a matter of weeks. So, one can argue with limited survival, should we be paying $100,000 if existing therapies are effective. Is that a good use of resources? At the same time, we don't want to inhibit innovation, and there will be treatments that work. So here's an example of taking the very same graphics that I've just shown and this limited survival, but looking at two groups. And if you're, again, receiving this drug in a certain vaccine, and in the group represented by the red line, at 48 months, there's no survival. But if you look at the blue line, within that same group, in a personalized way, 20% of people continued to be alive and probably will have long life expectancy. So how do we know who's going to respond? And that's, again, a reason why you can do some important clinical care and pricing considerations. Just to quickly go through an example that we looked at Anthem, what most of us don't recognize is oncologists' practices have much of their revenue and profitability driven by the ASP plus 6% model. So almost 70% of their revenue are from the markup of drugs, the 6%, and 32% of profits. So it's really important. And what we did at Anthem is developed clinical pathways, national guidelines, clinical benefit. These were developed by experts, a rigorous evidence-based process, as I said, with external advisors. They're publicly available. They're not one pathway per cancer. They're literally hundreds, many hundreds of pathways. And these next slides will show you some actual math of the cost of different treatments. These are treatments for a type of lung cancer, and you can see that a treatment, 4 cycles of chemotherapy that costs $500 or so has near comparable outcomes to one that costs $65,000. And what you also see shaded in blue are those that the oncology experts deemed as beneficial. So what we did, and this is, again, a model, is physicians, oncologists are getting all their customary payments, including the ASP markup. But if they follow a pathway, they are getting additionally about $4,000 a year for treating those patients to try to democratize payment. So there's not a disincentive to use the valuable lower price drug. Now, just to close, what does the future hold for all of us? And I think there's some models that we've learned a lot from. One is what's called the FDA Sentinel Initiative, now the Sentinel system. It's a model for collaboration. It's a model that PCORNet, a research outcome of Quarry, and the NIH, National Institutes of Health Distributed Research Network, will really promote. So today, the safety of drugs after FDA approval is being monitored by this Sentinel Initiative. It involves 18 data partners, most of the large health plans, many delivery systems. 193 million members are Americans. There may be some double counting there, are being evaluated in a distributed model. And as you look at the questions that have been asked on drugs based on almost 5 billion prescriptions, there are decisions that have been made, whether certain vaccines cause certain bowel problems, whether there are links to febrile seizure. So literally the safety of America's drugs are being monitored through this process. And this can be used in this distributed network to actually look at outcomes of care. So as we think of a path forward, certainly one can consider bundled pricing for treatment of patients with a specific illness. We know there's been bundled pricing in joint replacement and other approaches. We see value-based purchasing of drugs determined by clinical outcomes. We see real-world evidence development on outcomes following FDA approvals, as I've just mentioned. There will be new and emerging economic models to determine approaches to drug pricing. And most important for this audience, we really have policy and regulatory opportunities to promote several things. One is transparency. So a number of organizations are working to suggest changes with the FDA that allow pharmaceutical companies to share some of their label indications before final approval, some of their pricing considerations, to have a dialogue with payers in advance of approval. That's an example of a policy and regulatory opportunity. And the other one is to enable safe harbors within the Medicaid best pricing and 340B programs to enable some of these indication-based pricing. So with that, I'd like to not just thank you for attending, but we have some minutes for questions that you may have, and look forward to being responsive to them.
And I'd like to take this opportunity to remind attendees that they are welcome to submit questions in the Q&A feature in WebEx. Phone lines will stay muted, but you can type in your questions using the Q&A feature. And if anyone would like to follow up with the speakers following the webinar, you see their contact information is displayed, their phone number and email address if you have any questions that you would like to connect with them following the webinar rather than typing in your questions now. Okay, so it looks like we actually do not have any questions coming in. And so with that, I would like to thank Sam and Lesley for speaking on today's topic, and Connie joining us as a follow-up to yesterday's session. So in 2 to 3 business days, Epstein Becker Green will send an email with the webinar recording from yesterday's session and today's session. The recording and PowerPoint slides will be made available to all registrants. And this concludes today's webinar. Thank you for joining us.